We're going to have some fun today. We have 5 bills, and we're going to move along quickly. And that was Be Kind and Gentle by, who is Be Kind and Gentle by, I'm blanking on it. But in the future, we may do Toby Keith talking about me. So, because that's sort of what it ends up doing down here at the Gold Dome. But having said that, Reverend Jackson, do you mind bringing us to order and to pray over us, because we all certainly need that. You're on microphone 12.
Yes. Let us pray. Holy God, we give you thanks for this day, for the opportunity to gather with one another, to consider how we might care for each other. We pray for all who are in the medical field, for those who care, for those who are in need. We ask that you would help us to create laws that will help protect and to care well for all who live and work and play in this great state. Amen.
Amen. Thank you. So, as I said in the intro, we have 5 bills, and we have sign-up sheets down here. But as you imagine, we have other people that need to leave at 4 o'clock for other meetings. So we're going to try to be very efficient. We actually had the room until later, but I certainly don't want to take advantage of other chairmen from that perspective. So we're going to try to be very efficient. And in that light, for testimony today, the most powerful rules chairman ever, and distinguished too, he may just be keeping a clock on 2 minutes, and it may just go off and ring. So I just want everybody to be efficient. That's going to be a reminder, and we may bargain with people who may have come from faraway places that may get to stay a little bit further, because I understand there are some folks in the audience that may have come from another capital, not being Atlanta, but maybe D.C. So we'll see. The first bill we're doing today is going to be, we were doing Chairman Huffstetler's bill, right? 111. Senator Huffstetler, the 52nd. We have his bill. So let's turn in our folder and get to that one first. This is the one, if you remember, that was introduced last session and went through GORC. And that stands for Georgia Occupational something I can't remember right now. That will come back to me in a minute. Regulation Review Committee. Okay. GORC sounds a whole lot better, but that is what happens when we talk about changing relating to occupation. So, Senator Huffstetler, the floor is yours. You can stay in your seat to go to the podium or witness stand. Mic 12 for interest. We're going to keep you there. Floor is yours.
I had my other bill sitting out here ready to go looking at the order, but I'll be glad to do this one first. The anesthesiology assistants, everybody needs to know I am one. I've never done anything for them here. I guess this is my 11th year, and this is not a scope of practice change. But just like the CRNAs are sort of grouped in, had in the past maybe with the APRNs, advanced practice nurses, they're 2 separate training programs. And we have a separate training program. We're a physician assistant in anesthesia, and I think the group as a whole wanted to be recognized as a separate group. There actually were some things listed when they lumped us in with the regular PAs that we could do that we really don't do. So we've had this whittled down from different groups, and this will still have the same 1-to-4 ratio. An anesthesiologist watches 4 rooms. CRNA or an AA are in those 4 rooms, and they can't have more than 4 at one time. So they're the ones still in there doing it. But it separates them out in the code and recognizes that they are different from the regular physician assistant. As our chairman said, this went through the committee over the summer and was looked at. And I can get into specifics, but in time I can also just answer questions if there are about what this does.
Simply put, it went, AAs, anesthesia assistants, were under PAs, I could see how they may have done that initially, but it's certainly, they don't do the same thing. And so AAs don't write prescriptions like PAs, and PAs don't do anesthesia like AAs. And that's it in a nutshell. And we spent, how many meetings on that? 3 or 4 meetings going through all of that and hearing multiple, lots of testimony, and it was pretty simple and straightforward. So what I'd like to do is, he's presented the bill sort of briefly. Let's take a look at it in our folders, and we have 3 people that favor it, that signed up, and I think that if they, in an interest of time, if they want to just stand up and say who they are and that they support it, maybe at the podium would be good. Let's do Bill Bunton, Jennifer Stever, Jet Tony. Why don't we just come up to the podium, say who you are, and then we'll, and if you're okay to just say support, then we'll get the ball rolling. Bill Bunton's heading up there. Mr. Bunton is anesthesia assistant. He was on the committee with us on every call and is, if I remember correctly, president of anesthesia folks, anesthesia assistants in the state of Georgia. Immediate past president, and I didn't turn your mic on. There you go.
Thank you. I am in favor.
Well, I tell you what, he's winning points. All right, that's great. Thank you very much. Jennifer Stever.
Thank you, Mr. Chairman. My name is Jennifer Stever. I'm a practicing CAA here in Atlanta, Georgia, and I am also in support.
Okay, thank you so much. And Jet Tony with the Georgia Society of Anesthesiologists.
Thank you, Mr. Chairman, members of the committee. In your folder is a letter of endorsement from the Georgia Society of Anesthesiologists. The members of the Georgia Society of Anesthesiologists work with anesthesiologist assistants and CRNAs across this state in the anesthesia care team, which is the gold standard of the delivery of anesthesia and perioperative medicine. I will say that passage of this bill and creating a separate licensure track for AAs will allow AAs in the future not to be involved in a scope of practice battle that will eventually come to Georgia, where PAs may be looking for more independent practice. So this will allow these folks not to be engaged in that, and that'll give you one less phone call.
He couldn't resist it, could he? I got you. All righty. So thank you, Mr. Tony, and all of you, Ms. Stever, Mr. Bunton. Do we have any questions from the committee for Chairman Huffstetler on relating to this bill? At the appropriate time, it is.
Motion do pass.
Do pass, and it is seconded by our distinguished Rules Chair. And all those in favor say aye. Aye. All those opposed, like sign. So it is unanimous. All right. Thank you. The next bill, we'll stick with Chairman Huffstetler. Is that okay? Sure. Okay. All right. So give us just a second, if you don't mind, to if you'll look, we're at Senate Bill 46, and that's where we are. And Chairman, we're at LC 339362S. Is that correct?
Let me make sure that looks correct. Yes, sir. And I wanted to pass this around. It was printed just 3 days ago, where Mississippi was talking about having a 900% increase in syphilis. We thought for some years back that syphilis was kind of gone. It seems like we may have eradicated it, but then it's come back real strong, and we're seeing 3 times, 4 times the level of it, and it's particularly dangerous for those that are babies. If they don't get rid of it before they're born, there's really devastating effects from the long bones don't form. There's brain issues, nerve issues, anemia, severe anemia. There's a lot of factors there. Up to 40% of them will die before they're born if they're born with it. But those that are born are unfortunately going to end up being a ward of the state. And so we're seeing an explosion of this, and so the legislation, which the administration and the Department of Public Health supports, and I know that they're here to testify in behalf of this, would set up a testing method where they are tested at their first prenatal visit at 32 weeks and then at birth, so that we can start getting a handle on this. It's just an alarming increase going on right now. It also will be testing for HIV at the same time. The testing for syphilis is cheap. The antibiotics are effective. It's something we should be taking care of. If our former colleague was here, the retired OBGYN, he probably should carry this bill instead of me, but he's not. And with that, I'll answer any questions.
Do we have any questions for the chairman? Yeah, that may be the easiest thing to do. Thank you.
Thank you, Mr. Chairman. So in your original bill, there was no opt-out provision. So every pregnant woman had to receive this testing. But it looks like in the sub, now you're allowed to refuse testing. Can you speak to that?
It actually was allowed for them to opt out. It said later on in the bill, it said a reason being patient refusal, but that was a point people made, is it wasn't clear enough to them that they could. Now, I certainly hope they don't opt out. You know, when that sample's being taken and they're testing for everything else, let's test for syphilis too. But the intent was that we give the test. We certainly encourage them to take it, but they would have their permission all along to opt out if they wanted to. But I hope they don't.
Senator Lucas.
Well, why would we allow them to opt out? We do everything. When you first get in school, you had to be vaccinated to get in school, or you can't come in. Ain't no opt out.
No, there isn't. There are opt outs actually. Religious basis, there are opt outs for that.
Oh, on religious basis.
And there are opt outs now relating to them.
You know, the problem is.
Listen, I agree with you, Chairman. If you want to, do you want to hear from the legal counsel from DPH on that question? Because it's a little bit more complicated than just that. Be happy to.
Well, I'd like to know, because I think we're having all these kind of things.
Great, thank you.
Hey everyone, you all probably know me, Megan Andrews with DPH. As this testing is medical care, there is the patient choice for opting out of any sort of medical care, so we wanted to leave that option up to the patient. Obviously, there's a lot of implications for women that opt out, but their provider should be educating them on those implications when they're in that conversation.
I mean, personally, I agree with you 100%. I mean, and I think the numbers for people who opt out of this, I would presume are less than 1%. Is that an exaggeration?
I don't have data on the opt-outs because the positives are what's reported to DPH, gotcha. So we don't get all the test results.
Just personal experience. Chairman, mic number 2.
Yes, 2. Thank you, Mr. Chairman. Megan, besides the obvious answer, do we know what's causing the 900% increase in syphilis in Mississippi?
We actually have our chief medical officer here who is a physician and can probably better answer that question about the increases we're seeing. We do have pretty high rates in Georgia of syphilis generally and congenital syphilis.
We can get him up there. That'd be great.
Yeah.
Thank you. Just introduce yourself and just give us enlightenment. And you had a comment?
Well, I guess a follow-up penicillin, doesn't that cure
It sure does.
syphilis?
Yes.
So are we seeing new strands, or what's going on?
Yeah, so thank you for having me. My name is Dr. Alex Millman. I am the Chief Medical Officer at the Georgia Department of Public Health. So the rates that we've seen in syphilis increasing in Mississippi are something that we've actually seen nationally. Since 2012 nationally in the United States, we've seen syphilis rates go up by about 500%. Similarly, we've also seen our rates of primary and secondary syphilis as well as congenital syphilis increasing in Georgia in the more recent years. There's multiple reasons for this. Some of it is related to just changes in the way that STD or sexually transmitted infection care happens in the United States. There had been issues with disease contact tracers who were involved with following up on cases who, unfortunately, some of the funding for that at a national level has decreased over the years. And then some of the challenges that we also just have are populations that are at risk may not actually be getting the testing that they need. So in this particular case, given the high rates that we have in Georgia, it is very important that women do get tested at their first prenatal visit, that they get tested during the third trimester visit, 28 to 32 weeks, as well as at delivery.
Okay. Thank you.
That answer your question?
I don't have a follow-up.
All right, sounds good. Any other questions? Thank you, appreciate that. Thank you for being prepared. Didn't mean to put you on the spot there, but partly why you're here. Any other questions from the panel? If not, the Senator Setzler, Chairman.
Mike, too. Thanks, Mr. Chairman.
Okay.
Just really briefly, who's doing this testing? And if somebody is using I wouldn't say a non-traditional healthcare provider, they're not going to an OB's office. They have a home-based person checking on them. How does this get done in that setting? Because I want to make sure if we're putting a mandate on, we've just thought through that.
Probably the legal part of that would be Megan Andrews again on that.
All right, thank you.
So that would be on the physician. And do you mind if I grab a copy of your sub, Senator Huffstetler?
Okay.
So if you look at line 19 of the substitute, it says physician or other healthcare provider. So that would cover individuals that may be seeing like a certified nurse midwife or another provider that is not a physician for their regular prenatal visits.
Is this a pretty easy test to take? I don't know even the
It's just blood test.
Yeah.
So
Labs.
Okay, thank you.
Mr. Any other questions from the committee? If not, be happy to make a motion to do pass. And I called out the previous LC number, we're at 339362S, and have a second. Second, Senator Jackson, and we're going to raise our hands this time. All those in favor, raise your right hand. Okay, maybe I should have done it by voice. Okay, okay, all right, okay, thank you. Okay, so that was unanimous, and so that's Senate Bill 46. Thank you, Senator Huffstetler. That gets you for the day. All righty. So. So I know Senator Ellis has a meeting at 4. Anybody else have a meeting at 4? 1, 2, and does. Okay. So Senator Ellis, you're the only one who has a bill that. So let's go ahead and get yours done, if you don't mind. Is that okay? Get that done. Okay. And you're on mic number. On 5, and we are. Let's make sure we're all on the same page. Senate Bill 109, LC 339322. So there is no sub. And let me make sure I get there too.
That's correct.
Okay. Was printed twice. Okay. All right. Is anybody missing one? Because I got 2. All right. We're good. All right. The floor is yours.
All right, thank you, Mr. Chairman and committee, for conducting a hearing on this bill. A little bit of background. Currently in Georgia, there are 65 endocrinologists, and most of those are concentrated in metro Atlanta. if you live outside of the metro area, especially in South Georgia, you may be driving 2 or 3 hours to get to an endocrinologist appointment. On top of that, you may have a six-month wait to obtain an appointment to get in with an endocrinologist. Continuous glucose monitors let patients with diabetes see their glucose numbers continuously in real time, allowing them to make better diabetes treatment and management decisions with no finger pricks. Patients get alerted when glucose levels are heading high or low and can share that data with up to 10 followers, such as a parent or a caregiver. These medical devices have become the standard of care for patients on insulin therapy per the American Diabetes Association. For a Medicaid patient to currently obtain a continuous glucose monitor, that patient must see an endocrinologist to start the process. That process takes 3 to 4 weeks to work through the DME. That's Durable Medical Equipment channel. Many patients experience long waiting lists to obtain an appointment with those endocrinologists, and rural patients drive a long way. So SB 109 actually addresses that. It changes the coverage to a pharmacy benefit from a medical benefit. It changes the coverage criteria to align with standards of care, including the removal of all of the finger stick requirements and removal of the endocrinologist-specific prescribing requirement, and removal of the age restriction and updated insulin requirements. Basically, patients would be able to see their primary care physician in their hometowns and obtain the prescription for that medical equipment to be filled through their pharmacy. And that process takes 1 or 2 days versus 3 or 4 weeks. Benefits, there's savings to the state. I think that it's been estimated, and OPB has said that it could be about a $5 million savings annually to the state to do that. It improves coverage. I mean, we're talking about patients in rural Georgia and patients who depend on these devices. So this bill updates the coverage criteria to align with Georgia Medicaid coverage with the most current coverage trends across the country, including commercial plans. And about 90% of commercial plans do it this way versus the way the state is doing it now. Outcomes, the improved coverage can lead to reduced hospitalizations and improved A1C levels for patients with diabetes. Such improved health outcomes will generate even more savings, could be $2.5 million annually because of the improved health of these patients.
Thank you. Good bit. Okay. Do we have any questions? No questions at all?
I've been hazed at 1 o'clock today. Yeah, you missed. You should have been there. Should have been there.
Anybody?
Make a motion. Oh, I'm sorry. We do have somebody. Andy Lord, Mandy Reese, Diabetes Association.
Oh, sorry, not hazing.
Use the word hazing.
No.
Not a good word. All right, apologize. We're up here. All right, so we're going to get redirected. Andy Lord has the podium.
All right, thank you, Mr. Chairman. My name is Andy Lord. I represent the American Diabetes Association. I'm here with Mandy Reese, also from the Diabetes Association. We will be brief, Mr. Chairman. We stand in support of Senate Bill 109. We thank Senator Echols for bringing this legislation. And in addition to what she just shared, I'll be very concise. This bill will reduce hospitalizations. This bill will create cost savings through improved diabetes management, and this bill will result in fewer adverse diabetes events. I have a fact sheet up here that enumerates much of this. I will distribute this at the end of the hearing, but there's just one thing I wanted to point out. I want to take a moment to point out on this, and that is that we do have a study from the Journal of Diabetes Science and Technology that clearly shows that the use of a CGM in this study over the course of 9 months resulted in healthcare savings of over $4,000 compared to a patient who did not use CGM. So we believe this is not only great for diabetes patients, but it is also cost savings for the state, and Mandy will share kind of a on-the-ground account of that illustrates that.
Hi, I'm Mandy Reese. I'm a clinical pharmacist and a certified diabetes care and education specialist. I work in a family medicine practice with Northeast Georgia Health System Graduate Medical Education Program for Family Medicine. I'm the diabetes specialist in the clinic, and I have a CGM service line. I care for patients in the clinic who have CGMs. I'd like to tell you a quick story. First, I want to tell you about a gentleman. I'm going to call his name Bob. He has Georgia Medicaid as his health insurance plan. He is on 4 shots a day of insulin, actually 5. He was for a long time just getting his hemoglobin A1C checked every 3 months with numerous visits to the ER and put in ICU for blood sugars of 5 and 600. For the last year, we have been sampling him continuous glucose monitors. His A1C, which is an average measure of your glucose for the last few months, 3 months to be exact, should be less than 7. His was 11. Now it's less than 7, and we've continued to sample him. He even texted me today asking for another sample because his CGM is about to come off. There is older patients I work with who have Medicare coverage. The language for this bill aligns with Medicare and their criteria. And our older patients with Medicaid, we do get concerned about hypoglycemia, which is low blood sugar. They get a hip injury, they end up in the ER, and their mortality rate is 50%. There are 4,100 children here in Georgia with Medicaid coverage who need CGM. The folks who really aren't getting it is 1,800 adults who are covered with Medicaid who have diabetes.
Our timekeeper has.
Yes. Thank you.
All right. Thank you so much. We appreciate that. Thank you. And I'd like to recognize our President Pro Tem on mic number 8.
Thank you, Mr. Chairman. I'd like to make a motion to pass LC 339322.
All right. We have a second. Senator Setzler seconded. And again, let's do hand raise. All those in favor, raise your right hand. Okay. That's everybody. Okay. She raised her hand, and she very quickly. I saw it. She was quicker than the rest of us. Okay. Thank you. All right. So. Okay, so let me regroup here just a second. Senator Walker or Merritt, do y'all have a meeting after this? All right, I got you. All right, Senator Walker, we're doing Senate Bill 106, and correct me if I'm wrong, but let's look at Senate Bill 106, LC 339379S.
Thank you, Mr. Chairman. The committee seems to be in an agreeable mood today, and I hope I don't mess that up. We have a committee sub, and the only change in the sub from the original is line 9. We changed the name to the Healthy Babies Act. It was Healthy Mothers and Healthy Babies, and evidently there's an organization called Healthy Mothers, Healthy Babies, and to avoid any confusion, I thought it would be wise just to change that name. I'm probably a pretty unlikely candidate to be carrying this legislation. I'm not a OBGYN. I'm not a medical professional. I'm not a mother. I'm not a female. I may look pregnant, but I'm not. But I am a new grandfather, Mr. Chairman, and this is my new grandson. He's almost Cohen Walker. He was born in July.
What's his name?
Cohen Walker.
Cohen, great.
So he's almost 8 months old. I'll stop there. Thank you. But Mr. Chairman, I guess I was out at a SLC meeting in Oklahoma City, Southern Legislative Conference. Many of you attend those meetings, and we have seminars, and we hear from other states about what they're doing in their state, what's working, what their challenges are, what's not working. I attended a Medicare seminar out there, and me anticipating the birth of my grandson, I just somehow latched on to this maternal mortality
infant mortality issue in a bigger way than I had ever done previously. I've served on this committee a number of years. We've all heard the statistics. It's a national problem, and it's a Georgia problem with our infant mortality and maternal mortality, so I got interested in that. We've all heard the statistics. 53% of Georgia counties have little or no access to maternity care. Lots of Georgia counties don't have an OBGYN. I believe it's over 60 that don't have an OBGYN. March of Dimes gives us an F grade on our maternal and prenatal care. I won't belabor the statistics because I think we've all heard that and been aware of that. And I met a young man, and I think he's going to testify, Evan Hoffman in Oklahoma City at the SLC, and he was telling me about some technology that's available to help address the access to quality maternal care in rural or underserved areas, and it caught my attention, and I thought it was something that the Senate would be interested in leading on. And so I'm proud to bring this bill to you today, which would establish a pilot program through DCH for Medicaid mothers that are high-risk pregnancies to allow remote patient monitoring, and that could be a non-stress test, something as simple as that, which is basically a belt that the mother could put on and let a doctor monitor the heartbeat of the baby and that kind of thing, the placement of the baby and all that, all the way to ultrasound. And so when I got to talking to people at DCH about this, they're very interested in this idea. They do tell me we may have to, Mr. Chairman, massage some of the language to make sure that we get this paid through Medicaid. But I'd like to do that as the process goes on. But I also met with the Department of Public Health, and Dr. Toomey's keenly interested in this, and it really lines up with some of the initiatives she's already working on for rural health care, and I think this is going to work very nicely with a lot of synergy between different agencies that are interested in it. Basically, it authorizes or requires a 3-year study so that we can see what kind of benefit the patients receive. Hopefully, we'll have better outcomes and see what it costs and that kind of thing. So that's the crux of the matter.
Thank you, Mr. Chair. And let's do questions here, and then we have a couple people to testify. Do you have any questions for the chairman? All right, number 2.
Thank you, Mr. Chairman. Do we have any idea how will this work or would it work in conjunction with, DPH, I guess, has been making, or DCH has been making these announcements on the rural hospital, indigent care, Medicare, and all that being made whole? Is that going to work, navigate through that? Or, that may be a better question for the chairman. I don't know.
Well, we all work together, but DCH is the funding mechanism for Medicaid, and that which I think your direct payment plan is a drawdown from CMS. That's a further discussion. And if we have to perfect this bill as we go along, we're certainly all receptive to that and working with them.
It's a good bill.
So I think it will play together, work together. Mm-hmm. If we didn't learn anything from the pandemic, is that telehealth is a good thing and is a positive thing. If we do anything to encourage that, I think we should continue to do that. And DCH is receptive, and Department of Community Health, which is Medicaid, right? That's the folks who paid the bills when it comes to that, and then Department of Public Health, which was certainly instrumental when it came to the pandemic.
Chairman, could I interject?
Absolutely.
I should have already mentioned this, but y'all might find comfort in the fact that Dr. Dean Burke, who is our Medicaid director now, is working with me on this. and
He
helping
is.
me.
He's fabulous, and he's doing great. Kaylee Noggles, the executive director, he's the chief medical officer,
Okay.
and they all work together, and we can continue to work with them. Can we have Evan Hoffman, if there's no other question? All right, for the chairman, witness number 2.
Number 2, thank you, Mr. Chair. Thank you for bringing the bill, Senator Walker, and it's critically important. Just going forward, you may not have the answer today, but I know in terms of eligibility, what understanding what slice of our population is eligible, because we have, really, in some cases, people can't earn over $9,000 a year. So I don't want to misspeak on that.
So this is a pilot program,
Right.
and if you'll see in there, that's on line 63, and then the number 55 recipient lives in a county without a licensed OBGYN who
Right.
participates in state Medicaid program.
And has those, an increased likelihood of a high-risk pregnancy, and all that's listed out lines 47 through 54.
So could we get, if you don't mind, Evan?
So is that we can get an answer on that, so we understand it? I don't mean today, right now, but I'll just follow up on.
We'll certainly circle back.
What
and
income level is being
would be
covered with this,
Yeah.
and
Well, this will be Medicaid,
Yes.
maternal. So, the extensions that we gave to Medicaid, it's 12 months now, right?
Postpartum 12 months.
Postpartum, 12 months, and of course, prior leading it with the pregnancy, so with first prenatal visit kind of thing.
Mm-hmm.
Okay. I don't know how the large number is. I think that's the question, is how many people will be served by this pilot project? Is that the question, Senator Ora?
It's really with the operating under the current Medicaid rules, and this is addressing, shifting some of those, adding some requirements. What slice of that population are we capturing? Is there any?
So this will be a pilot, and so the number that are in the pilot is left up really to the discretion of DCH, the way the bill is currently written.
It's for on line 35, 36 for women who are eligible pursuant to subsection C of this code section for up to 12 months postpartum, and that C specifies a number of conditions. If I'm reading it right, it's not a.
They got money.
And it's a pilot, yeah.
It's a pilot, you got to pay for it.
Well, and Dr. Toomey's very familiar, a long history of running pilots and getting compelling results. She's done a lifetime of that work.
Thank you. Mr. Hoffman, would you mind identifying yourself and where you're from and who you represent? And
Sure.
the floor is yours, and you're on the timer.
Great. Thanks, Chairman Watson. And Senator Orrick, I can address that question as well. My name is Evan Hoffman. I lead state and local government affairs for Philips. Really happy to be here. Thank you for having us. So Philips, we're a health technology company that employs around 800 people in Georgia. And while we no longer have the naming rights of the Hawks basketball arena, we do work with providers all across Georgia in improving health outcomes. Most consumers know Philips for our Sonicare electric toothbrushes, but we are one of the have such a deep legacy in maternal and infant health. We're one of the world's largest ultrasound and obstetrics monitoring companies. We also run Pregnancy Plus, which is the world's most downloaded pregnancy app that 80,000 pregnant individuals in Georgia used last year. So I ask everyone to imagine today that you are one of the 25 to 30% of moms who find themselves with a high-risk pregnancy. You're singularly focused on keeping yourself and baby safe, but this may mean going to the doctor up to twice a week, especially in your third trimester. So making all these appointments is obviously very difficult for anyone. Many moms face that impossible choice of making their appointments, but they can't afford to take off work, don't have reliable transportation. Perhaps they don't have someone to watch over other children, or they live far from their doctor. And we talked a little bit about maternity care deserts in Georgia. So 300,000 women in Georgia live in these maternity care deserts where they don't have access to care. And while we appreciate this body's work to improve maternal health over the last few years, there is additional opportunity to expand upon this great work and enable access to healthcare technology that can help improve care further. So as mentioned, this bill equips doctors with the option of offering their patients remote maternal health care services when appropriate. So I'm going to kind of talk through some of the technologies in the bill so everyone's aware. So take remote patient monitoring, which allows providers to remotely monitor a patient's vitals, like blood pressure and heart rate. So imagine if doctors were warned sooner about complications, almost like a check engine light for your car. Then doctors could intervene quicker, adjust care plans, and prevent the hospital visit.
Thank you, Mr. Hoppin. Where did you come from today to testify? Where?
Northern Virginia.
Northern Virginia. You get an extra minute, so
okay.
Go.
I appreciate that. Thank you.
The chairman's decision.
Yes. Or take tele-ultrasound, which was mentioned. My written testimony that I submitted outlines the work of Dr. Michael Ruma in New Mexico, who opened 7 satellite ultrasound clinics across rural New Mexico, and he has reduced the travel time by all his patients by 38 miles per visit on average, and he has patient satisfaction scores of 100%. Or take the non-stress test, one of the most important screening tools for moms with high-risk pregnancies, prescribed in the 3rd trimester twice a week. The FDA has now approved technology to enable the non-stress test in the home. My testimony shows a lot of different medical studies that show cost savings, improved outcomes, so I would encourage you to take a look at that. And also look at other states, what they're doing. 36 states cover remote patient monitoring for their Medicaid beneficiaries. Both Texas and Virginia have strong models for pregnancy specifically, and Missouri has a very strong model for remote non-stress tests for their Medicaid beneficiaries as well. I think the March of Dimes submitted a letter of support along with a variety of physicians, so thank you for being here.
And thank you for coming here and sharing those numbers in a other state perspective also.
Yeah, that's helpful.
Thank you so much. Ashley Haltom. I see Georgia bio. Okay. If you mind identifying yourself, who you with, and the floor is yours.
Absolutely. Hi, everyone. I'm Ashley Haltom. I'm with the Center for Global Health Innovation, formerly known as Georgia Bio. But specifically, I'm here today representing our Patient Advocacy Alliance. We represent patient groups from across the state in all areas. And one of the missions of the center is better health outcomes for our citizens. This is an excellent bill. We're so excited to be part of it, or to be supportive of it. We think it will offer not only better health outcomes for the mothers, but certainly the babies as well. And on a personal note, I had my first son in July, and I was fortunate enough to have access to exceptional care right down the road. I'm actually from Senator Walker's hometown, and I know that that's not always the case, and not everyone has that fortune. So happy to support it personally as well.
Well, we're so happy for you and your child. Thank you. Thank you for being here. And any other thoughts or questions or concerns? Senator Hatchett is on number 9. Oh, somebody put the numbers up there. That's good. Thank you.
Oh, that was smart.
Just for clarification, this technology obviously exists now. Are physicians not allowed to use it in the state of Georgia right now? I'm just trying to.
Does the chairman, are you able to answer that, or do we need to get?
My understanding is they are allowed to use it as getting paid.
So the Medicaid reimbursement, is that Senator Kirkpatrick is on number 11?
11, thank you. Yes, Mr. Chairman, I was going to point out that this program is operating in Georgia for high-risk patients, and there's a group right here in Atlanta that has 4 physicians who only do remote patient monitoring for high-risk moms. The question is the coverage under Medicaid and how to make it more available to the people that need it. So I think that's what you're trying to do, and I congratulate you for that.
But you got to get CMS to agree to.
I'm sure that's always the case, right? Yeah. Any other questions or concerns, or any, looking around, no other questions? Be happy to entertain a motion. All right. All right. Senator Orrock, do pass. Second by Senator Lucas, and we're all in agreement. Any further discussion? If not, all those in favor, raise your hand. Okay. All righty. Looked like it's unanimous again. It is. It is. Thank you, Senator Lucas.
Thank you.
So and
Thank you all.
we're doing well with time too. Wow, it's amazing. All right. Last, certainly not least, is Senator Merritt. And it was confusing to me earlier. We're on SR, Senate Resolution 46. I'd gotten that confusion with SB 46. So let's be, everybody look in their folders. There we are, our last bill. And, okay, Senator Merritt, why don't you go to the podium, because it's pretty tight around this table. Okay. And so the floor is yours.
I sure was hoping I was going to be first. It's been a long day. Thank you, Mr. Chairman, for allowing me to present this resolution to my members today. So this resolution actually dovetails off of a bill I just had a hearing for in insurance and labor. And that particular bill was to cap the insulin costs for state health benefit plans. That's just merely what it would do. It would help our employees. It's just expanding more options for lower insulin costs. As I come from a family that is insulin dependent, I have insulin dependent friends, and we probably do have members here. I know Senator Lucas is, that relies on insulin as well just to live. So from that bill, this is my larger plan or my master plan, and it was just to bring more attention and just to think about this possibility. And as y'all read in the resolution, you see where insulin cost is, and it's expensive. You know, people need it. It's life-saving. They need it to live. Other countries and states, other countries have already invested in the development of low-cost insulin for their residents. And the production of low-cost insulin products by the state would ensure that Georgians with diabetes would have access to life-saving medications. And the other part of the bill I want to discuss, is just how the opportunity it would have to build business here in Georgia, to create jobs here in Georgia. And it would open us up to a market to lower those costs and help Georgians stay healthy. Right now, there are only 3 major insulin producers, and it's expensive. 3 companies. So we see an opportunity here for Georgia to be on the map and get into the industry. Other benefits, as you may ask me, what other benefits are there, Senator Merritt? I'm going to name a few. It benefits our universities. We can leverage world-class research universities in Georgia, explore the most cost-effective and strategic applications of planning. We can also become a net importer of talent. Rather than training up those incredible engineers and sending them off to other states, we can have them stay here and help in the production. I've already spoken with Bert Reeves, former Representative Reeves over at Georgia Tech, just to kind of get an interest of what it would be and how we can maybe have Georgia Tech help us partner to make this a reality. You know, they have a bioengineering department, and he expressed interest in helping consult on a larger project so that we can leverage this to Georgia's advantage. It's good for business. Simply put, this is a huge business opportunity for the state of Georgia. This will create jobs and long-term infrastructure investment. Again, it's good for state employees. I've already had a proposal to cap that insulin cost for state employees to make the state more favorable towards retaining and caring for individuals with diabetes. You know, I come from the corporate world. I still will maintain you keep your workers happy and healthy, and they stay. And lastly, diabetes patients. We're prioritizing the research, production, and innovation in Georgia, and we will be able to ensure that Georgians never have to fight for supply shortages, as well as combat the rising cases of diabetes throughout Georgia. And as you can see in your handout packet, the cost of diabetes on Georgia's taxpayers is significant. By treating this disease, we will be able to save millions of dollars annually in healthcare costs and missed work output. Now, this certainly will be a tremendous cost, and I will be seeking this to maybe move to a study committee is where I would like it to go, and have that committee to approve so that we can explore a comprehensive cost benefit analysis to determine the viability of this proposal. This is certainly there's some controversy around manufacturing initiatives such as hemp in the state of Georgia. This, however, should be no controversy around manufacturing insulin. This is to help people live. So I am asking for your favorable consideration of this resolution. Thank you. Any questions?
Thank you, Senator Merritt. I have a question here.
Thank you, Mr. Chairman. Thank you, Senator Merritt, for bringing this. You know I love urging resolutions.
Urging, yes.
So I guess my question, you said you wanted to get to a study committee. So why are we urging the governor to study it? Why don't we just study it?
And we are, and I guess this is just step one. I
feel
kind of
like he's got a lot going
I had a
on.
step one and a step two. So this is we're just bringing attention to the master plan, and then just urging the state, the governor, to look at this more closely. But broadly, yes, I would like to see this go.
And you know,
into a study
listen, the
committee.
executive branch may have a lot more resources than we have, but
More resources. Thank you, Mr. Chairman. More resources, more ability to do what I'm asking.
Any other questions, Senator Setzler? You going to borrow number 2?
Mr. Chair, I appreciate the lady's interest, and I love the idea of being able to produce, vital things like this in the state. Why don't we just make this a study committee resolution and establish one and have point members? I don't see any resistance from the governor in doing this. I don't think the executive branch is going to be stopping us. Does it make sense to do this and not just make this a study committee resolution?
That's something to consider. I had not, I really just wanted to have Senator Merritt bring it to us and discuss it, and if we want to come back with that, or we can pass this and come back with your second option, that's also available too.
As a legislature, I wouldn't want to say, Governor, we're telling you to go take care of this, go do this.
Okay.
It seems to me, it just seems to me like we ought to say, we want to do this.
Yeah, I mean, the will of the author and the will of the committee, if we'd like to table it, rediscussion it, bring it back, I'm here at the will of the committee.
I got a suggestion.
We have a suggestion from Senator Brass.
If you would just simply go to Ledge Council and get a new one drafted, it would go straight to rules.
Well, suggestion there.
Well, hey, that is an option
Just
as
a
well.
suggestion.
So,
okay.
You went over our heads a little.
If you would simply go back, whatever amendments we might offer to make this a study committee, just simply go get a new bill drafted with your similar language, and then study committees are all getting referred to rules, so it'll go straight to the standing committee and rules.
That's fair.
And then you bypass this step.
Same numbers, make it bigger.
It's teamwork makes the dream work. There we go.
Thank you all for listening. Thank you, Mr. Chair.
Is that amenable to the author?
Yes.
Yes. Good suggestion.
Great suggestion.
And Senator Mayor, I think the rules chairman may be one of your signers, so you should get a good.
But to your point, that it was just broadly asking the governor for the help because, again, as the chairman said, he has more resources than I do.
And we can certainly discuss that further offline.
I'm going to stop saying that.
Anything else from the committee, or any questions or any concerns? I see people looking at their watches. We've been very efficient. Thank you, everybody, for doing that. Thank you, Senator Merritt. And we are, let me just a reminder, we're not in session Monday, so our next meeting will be Wednesday. I promise more controversial bills in the future, but I appreciate everyone's attendance. Thank you. Next meeting next Wednesday. Thank you.